Philadelphia International Medicine, PIM, provides international patients and physicians with access to an unmatched network of world-renowned doctors, surgeons, and hospitals that deliver personalized medical, surgical, and rehabilitative care ranked among the best in the world. Since 1999, Philadelphia International Medicine has helped patients and physicians from around the globe eliminate the guesswork, planning, and anxiety of finding and connecting with doctors and hospitals ranked among the best in the world. With 8 hospitals, 2 medical schools, 2 cancer centers, and hundreds of top doctors, only PIM can bring you into its medical family with one easy phone call or email.
Temple. So let me just start off with a case. So this is a patient that I've seen, so a 53-year-old female who presents with progressive shortness of breath, dyspnea on exertion for a few months. Her past medical history is notable for iron deficiency anemia, hypothyroidism. She had a gastric bypass 10 years earlier, and also some knee surgery even before that. So her workup, so she'd seen her primary doctor, her chest x-ray was normal, she had an echo, cardiac cath, all of which were normal. She was even evaluated by a pulmonologist who very astutely picked up the fact that she was stridorous. So she had this noisy upper respiratory sound on his exam. So he ordered pulmonary function tests, which revealed a variable extrathoracic pattern, ordered a chest CAT scan, and then referred her to treatment to see us. So here's her flow volume loop, and you can see clearly it's not normal, particularly this one on the left here. You can see this typical kind of cookie cutter pattern, which is always worrisome for a fixed type obstruction. Here's her CAT scan, just scrolling through it. Not particularly revealing, we'll talk about that in a second. You know, perhaps a little narrowing up here just below the vocal folds. And the reason for that is because of how thin the cuts are. So if you don't get very thin cuts, you can often miss it, which is kind of the case here. You know, you can't really pick up on it too much. When I examined her, the physical examination showed mild inspiratory stridor, particularly when she had deep inspiration. So taking a deep breath, you can clearly hear it. You know, had a deviated septum. Remainder of her head neck examination was normal. The one thing I did notice is that when I passed the scope, the flexible laryngoscope, to look at her larynx, she had a little bit of just bleeding when that took place, and it doesn't happen too often. So I thought that was kind of interesting. So here's her laryngoscopy. I just shut off the audio because it's a little bit noisy, and you can see passing a scope through her vocal folds. Clearly see here an area of narrowing, and I said this is probably about easily 50 to 60% stenosed. And you can do this in the office with a little topical. You just have to topicalize the vocal folds. You know, some patients tolerate it more than others. Let's just go back one more. So here is her laryngoscopy in the operating room. So we have her under jet ventilation here. A scope is sitting just below the vocal folds, and I'm passing a telescope in to look. And you can get a pretty good idea. So, you know, it's a short segment. Distally, it looks normal, but clearly it is a narrowing here. And again, about, you know, 50% or so circumferential. So we treated this kind of the way we usually do with a laser, and I did kind of cuts here at 3 and 9 o'clock. And then, so usually do that with a laser followed by dilation, steroid injection, and mitomycin C. And we'll talk about each of those later on. And that's what she looks like when we're done. So her post-op course was unremarkable. Always when we see these patients the first time, we get a biopsy from the subglottic tissue because we want to look for things like vasculitis and granulomas, to look for sarcoid, Wegener's. In her case, all it showed was inflammation. There was no evidence of vasculitis or granulomas. We also send off serology, which is very, very important. So her ACE was negative, but her P-ANCA was positive, and 1 to 640. So again, a pretty high dilution. So she had a significantly positive P-ANCA. Repeated it because, you know, it can always be issues. So we did do that, and it was again positive. Her myeloperoxidase antibody was also positive. Urinalysis, because Wegener's can involve the kidneys, of course, was negative. So she was referred to rheumatology, who had been treating her now. She's 4 of them at a time, or other office in which they tape. Now getting to our topics, this first patient that I presented was obviously a case of, somebody who had Wegener's, so an autoimmune type stenosis. There are other types. In fact, this is a very, very old condition. In the early 20th century, the main etiologies were actually infectious. So TB, diphtheria were the most common causes. Chevalier Jackson here, who ended his career at our institution at Temple, and was the father of modern day bronchoesophagology, certainly in the US, brought attention to the high tracheotomy being a cause of iatrogenic stenosis. World War II, many more motor vehicles on the road and people not wearing seatbelts. Remember, seatbelts came along later. Patients' necks were crushed during car accidents against the dashboard, so it caused a crash against the larynx, the so-called padded dash syndrome. So crushes the larynx against the spine, and that was the main cause around that time. In 1970s, so endotracheal intubation, particularly used during the Vietnam War, helped rescue a lot of patients from respiratory illnesses and improve their outcomes. But unfortunately, as a result of the tubes, we had many more of the stenosis complications. 80s, 90s brought along these, off-road vehicles, particularly snowmobiles or mini bikes, ATVs. They caused a lot of clothesline injuries as people were, driving along off-road and a tree or a line of some type hit their neck and caused significant injury. And in the 21st century, we, not that it hasn't been around before then, but we're much more, acutely aware of idiopathic and autoimmune, and we have better treatments for them too, like the rituximab in the first patient that I presented. This is a paper way back from 1992. But believe it or not, the etiologies haven't changed significantly. Still, the vast majority, about 60%, even more, 60, almost 70% are going to be endotracheal trauma or external tracheal trauma, with other reasons being much less common. And this is from our own data here at Temple. This is a paper we published back in 2007, and we had looked at 8 years of our data, so about 74 cases of adult laryngotracheal stenosis. And you can see it's fairly similar. Again, tracheotomy, the things that put you at risk were previous tracheotomy, almost an 11-fold increased risk of having stenosis. If you've had radiation for a laryngotracheal tumor, almost 6-fold risk. Previous intubation, about a 4-fold risk. Again, sort of very similar etiologies. The etiology, of course, is going to vary somewhat depending upon where you practice. So if you're, for example, at the Cleveland Clinic, where that's a huge referral center for autoimmune conditions, they see lots and lots of Wegener's, that's going to be your primary cause. If you're in a location, Seattle, for example, or Portland, where there's a large population of females from Northern European origins, you're going to see much more idiopathic stenosis. However, still the vast majority in all institutions is still going to be iatrogenic or trauma. And a more complete etiology, as we're saying, is going to include these chronic inflammatory conditions that I spoke about, so the Wegener's like in our patients, but also TB, believe it or not, it still comes around. And depending upon where you practice, you can still see it. Sarcoid, very common. Relapsing polychondritis, not so much, but you have to think about it. We do still pick up a case here and there. Bullous diseases, cicatricial pemphigoid in particular, which is a scarring disease, can cause this, and I have at least one patient with this condition. Neoplastic disorders, again, that's probably, goiters in particular can kind of cause crushing of the larynx. Thyroid cancer can invade. And then the idiopathic you have to think about, because that group is not going to be the typical. It's going to be young females who have not been manipulated at all. They haven't had any endotracheal intubation or trauma or tracheotomy yet, present with a stridor, and often are confused and misdiagnosed as having asthma. In fact, the typical patient with idiopathic stenosis will go on for more than a year being diagnosed and treated for asthma before somebody picks up as to what they have. So we classify this much like we do for any other condition, and so it helps us kind of sort it out and treat it and study it. And very similar to the way we, sort out cancer, classify cancer, for example, it's anatomically. So we divide it into glottic, so at the level of the glottis, and it can be both, anterior, posterior, or complete. Subglottic, upper tracheal, which can be, anterior only, often as a result of a tracheotomy, or circumferential from the endotracheal tube cuff, or some combination of the above. And I still use this regularly. So let's just talk a little bit about the pathophysiology. So for external laryngeal, because it varies depending on the etiology. So if the external laryngeal trauma, the most common, the typical pathophysiology is that you get some fracture, so that is disruption of the cartilaginous framework. Then you get a hematoma between the perichondrium and the cartilage. And the mucosa is disrupted, as the hematoma is reabsorbed, the cartilage is lost. And the reason for that is that the cartilage doesn't have its own blood supply. It gets all its nutrition from the overlying perichondrium. And if there's a hematoma there, there's basically no blood, no blood supply, no nutrition given. So the cartilage dies off. This is pretty similar to what happens when you get a septal hematoma, if there are any otolaryngologists in the audience. The same concept, you lose the cartilage because you have a hematoma there and you're not able to get any nutrition to the cartilage. So as a result, when you lose the cartilage, what replaces it? It's collagen. And then you get scar contracture. Collagen is one of the main components of scar. And because the trauma can be anywhere, the location of the stenosis can be anywhere. It's going to be a variable location. So contrast that with endotracheal tube trauma. Very different pathophysiology. So you've got more of an ischemic necrosis. So you have that endotracheal tube sitting against the posterior glottis, and the cuff sitting against the upper trachea. So what happens there, again, there's, the pressure causes mucosal ulceration. Then secondarily, the bacteria come in, that area gets infected. So as a result, you get perichondritis, chondritis, and again, and submucosal fibrosis. And again, with any scar, that scar contracts. And again, because of the typical locations, you're gonna, that endotracheal tube cuff sitting against the posterior glottis, that's gonna be one of the main locations, and the other one is where the cuff is, and that's the upper trachea. There may be a genetic component to this, or genetic predisposition. This is actually, again, some of our work here at Temple, in conjunction with the School of Pharmacy, the Pharmacogenetics Laboratory, Dr. Kranitsky and colleagues. We looked at a variety of single nucleotide polymorphisms in patients with stenosis and those without stenosis, and then we did a pretty sophisticated kind of statistical analysis. And what it showed is we found actually at least 3 different SNPs, these single nucleotide polymorphisms, which made patients more susceptible to having stenosis. In fact, more recently, our work, again, with a similar technique, we found that actually that African Americans actually may be more likely to have one of these SNPs that predisposes them to having acquired laryngotracheal, or developing acquired laryngotracheal stenosis. So this was really an interesting find, particularly in light of the fact that idiopathic subglottic stenosis is much more common among Northern Europeans, particularly Northern European females. Although we haven't studied that, we only have very preliminary data on that group, it is clearly a genetic component. And although it's not really fully clarified, I think there's going to be probably a genetic predisposition to getting acquired, and one for the idiopathic as well. So switching gears again to the clinical presentation. So how do these patients present to you? So when you see someone in the ER, when you see someone in your office, what's going to be the picture? So it's going to be patients with hoarseness, and they're going to give you this history of progressive respiratory difficulty over time. Usually it's a matter of a couple of months, particularly for the traumatic or endotracheal tube, the acquired types. And on examination, you can hear a noisy upper respiratory breathing, so a biphasic stridor, which is indicative of a fixed stenosis. And in the patients that are, again, that are acquired, they'll have some history of a laryngeal or a tracheal insult, either intubation, tracheotomy, and then decannulated, and then over the next month to 2 have become, more significantly short of breath. So contrast that with the idiopathic type. That's going to be those, females, middle age usually, although some will be older, Caucasian, particularly again of Northern European descent, and will have no history at all of significant laryngotracheal injury. In fact, by definition, in order to have idiopathic, it must have been 2 years, at least 2 years before the last time they were intubated or had any kind of upper airway manipulation. You know, no previous surgery, no radiation, no thermal injuries or caustic ingestions. And you need to check blood work, the serology, to make sure they don't have any evidence of vasculitis. Biopsies in particular are useful, again, to look for vasculitis or to rule that out, although they're not always conclusive, as we showed you in the patient that I presented initially. So again, this is, and you can see their pathophysiology. This is from Guri Sandhu's group in the UK. The problem is not the cartilage here. It's a submucosal fibrosis in the lamina propria. So it's a very different kind of condition, and the acquired invariably, like I was saying, is a chondritis or a perichondritis, and there's some cartilage damage. In this group, there is none. It's all submucosal. So again, there's a lot of work being done on this condition. We think maybe it's related to other types of fibrosing conditions, like pulmonary fibrosis. But again, the work is ongoing, and there's a lot more that's going to come on this. So when we examine patients in general, whether they're idiopathic or acquired, you know, laryngoscopy is very important. Like I showed you in the first patient, you know, you look at the larynx, you topicalize, and you get a look below the glottis as much as you can. This works better in some patients than others. And you're going to see, we're going to sneak in here, and you're going to see a pretty significant stenosis. This is pinpoint. This is probably 80 or 90%. Somebody, again, this was somebody that had a history of asthma or COPD and had multiple intubations, and the symptoms were chalked up to, you know, exacerbation of the COPD, when in reality it was a stenosis from all the intubations that he's had. So radiographic imaging is interesting, right? So there are a lot of tests that you can certainly order. I can tell you probably the single most useful one is going to be a CT. They can be done very, very rapidly. I mean, literally in under a minute, you can get a lot of cuts, even if you do them very fine. And that's the caveat here, is that's got to be 1 millimeter cuts. If you're not, you may often miss it. You can even do 3D reconstructions of them to kind of give you an idea. And you can see a patient here who's had some trauma, and you can see I'm pointing out to the area of stenosis here. Flow volume loops, like we saw earlier, is probably the single best pulmonary function test that you can use. And there are portable units here that are available that are pretty cheap. You have the patient basically inhale deeply to total lung capacity and then forcibly exhale. You usually do this 3 times, and you kind of get an average. And this is the typical cookie cutter pattern. There is some data available from way back, particularly from the recurrent respiratory papillomatosis from the late Dr. Kashima, that showed that if you have a peak inspiratory flow here of less than 1 or 1.5 liters, you're going to be significantly symptomatic. You can see this patient isn't quite so bad. They're just around 3 liters, although they are still symptomatic. So most of these patients will go to the operating room for treatment. We examine the area endoscopically, like I showed you earlier, using a microscope and telescopes. And there's a variety of things that we do, especially during the first assessment, but certainly every assessment. So we examine them and determine how long the stenosis is. That's going to be very important. Width meaning sort of how narrow. So we'll give it a percentage, you know, 30, 40, 50, 60. And there are some devices available that can do this objectively. Most of the time we're doing it based upon my experience and a sort of a subjective evaluation. You know, in pediatrics, they use endotracheal tubes to size. We don't really do that for adults. You want to determine its location, particularly the distance from the true vocal folds. That's critical. The reason that's critical is that the closer you get to the vocal folds, the worse your outcomes are going to be. That's very important. You know, tracheal stenosis has a much better outcome. Prognosis is going to be much better. Isolated tracheal stenosis, 3-4 centimeters from the vocal folds, than posterior glottic stenosis. And you want to determine, is it soft or fibrous, so sort of how much inflammation there is early on. After you know, developing the stenosis, it'll be more granuloma, you know, sort of inflammation, granulation tissue, and soft. With time, that'll become much more fibrous and scarred. We determine arytenoid mobility, particularly if you've got a posterior glottic stenosis. You want to figure that out. We take lots of video and photographs for documentation and for discussion with colleagues, et cetera, for presentations, of course. But it's good because again, we see so many of these, it's often difficult to remember which one was what. And so, you want to have video documentation. It's very, very helpful. Put it in a patient's chart. So here's some examples. This is someone who's got a supraglottic stenosis. You can see the whole right vocal fold here is gone. In fact, all you see is the false vocal fold. And you can see this patient has a tracheotomy and some tracheal narrowing as well. Right, scar band across it here. Again, you can tell this is a typical external laryngeal trauma. And here's another one. This is someone with, in fact, this is the patient I showed you earlier with the multiple intubations for COPD. And you can see here it's tracheal, but it's multiple levels. So it's a long multi-level stenosis, which is going to, again, decrease your results a little bit. Although, again, if it's purely tracheal, your outcomes are still going to be better than if it's subglottic or upper or posterior glottic. Here's another one here. This is, you can see my copper catheter for jet ventilation, subglottic jet. This is someone who had a traumatic tracheotomy. And you can see there's probably some cartilage crushing here and scar bands. So it was a young woman that was in a motor vehicle accident. And it had intubations and tracheotomy. It was really quite a mess. But amazingly, we were actually able to open this up and get her normal and decannulated. And she's at least 4 years out now. And you can see it's relatively fresh because you can see that there's granulation tissue, not just all scar. And this is someone here who's had a percutaneous tracheotomy. And you can see the cartilage is pushed in and it's kind of raw cartilage. And whenever you have raw cartilage, it'll get granulation tissue. Now, luckily, we were able to pick up on this relatively quickly after the percutaneous tracheotomy and determine that, this is what's going on, and we cleaned it up and we're able to get him decannulated. Let's see. So this is one more here. And I'm going to point out sort of this interesting configuration. You have this kind of scalloped area here. This is a typical pattern that we see in patients with idiopathic subglottic stenosis. So again, those middle-aged females from Northern European descent will often have this pattern. I'm not sure what it means, but we do keep it in mind. Hopefully it'll mean something, and I'll figure it out at some point as to what it means, but we see it quite often. It's a typical looking pattern. And again, whether they've been operated on or not, we always see this. So not often, often see it, not every time. You can see again, usually short segment, subglottic or upper tracheal, and distally normal all the way down to the carina. All right. So I mentioned mitomycin C earlier a bit. So this is an anti-metabolite. This was initially used in the ophthalmology world to help fix pterygium. And then we adapted it into otolaryngology in sort of the early 21st century, early 2000s. I think was the first publication on this. So it works by preventing scar formation. And this was Marshall Smith from Utah, who did a trialogic thesis on this. What he actually showed, because of the way it works, it's only good for a short period of time. The theory behind this hypothesis is that if you use it more than once, it may have a better outcome than just one. So he did a very nice prospective study. And what he actually showed is that early on, 2 treatments were better than one. So the recurrence rate was significantly less. So 7% versus 33, 14 versus 33. But look, as time goes on, and this is the yearly stenosis relapse rates, there's no difference. So by 5 years, if you use it once or you use it twice, it really didn't matter. Early on, it may have made a difference. So we still, in my practice, we use it once. If they need further treatments, we use it then as well. But we don't bring them back. He was bringing them back a couple of weeks later to apply it a second time. And there are some other medicines that are on the horizon. This is a study. This is from the Hopkins group looking at rapamycin. And again, this was a laboratory study which did show, improvement in it basically decreased fibroblast proliferation and metabolism in vitro. Again, it hasn't been applied clinically. And another one here, tacrolimus, although this is interesting to me because tacrolimus is one of the medications that's widely used in transplant patients, lung transplant patients, for example. And, they have their own set of issues regarding stenosis at the anastomoses, despite being on this medicine. And again, this was a rat model out of Japan. So again, I'm not sure what this means. It did seem to help if when they gave it IV in laryngotracheal stenosis, but again, it hasn't been applied in vivo or in humans. So let's talk about each of the stenosis, the types of stenoses anatomically. So an isolated supraglottic stenosis is actually pretty rare. So invariably, it's going to be the result of some kind of unrecognized injury, at the level of the thyrohyoid membrane up here. And you can treat these in a variety of different ways. You can use a transhyoid pharyngotomy. Let me show you this one video here. Let me see if I can move this up. And you can literally see here an area where it looks like the part of the thyroid cartilage has been pushed back, and sure enough, right there. Luckily for this young one, so this is a woman that was in a passenger in a motor vehicle accident, unbelted. Her neck struck the dashboard and again caused this fracture. Luckily for her, her airway wasn't an issue, neither was her swallowing, but obviously her voice was terrible. Again, you can treat supraglottic stenoses. Again, they're all going to be slightly different in a variety of different ways. So sometimes endoscopic laser, that's always usually our go-to early on because it's much less morbidity and faster. But sometimes we've got to proceed to doing a supraglottic laryngectomy. We've had to do that in this group, or some kind of transhyoid pharyngotomy to get access, sort of the same techniques you would use for head and neck cancer. So again, a typical kind of fracture, and then falls back as I showed you here. So anterior glottic stenoses can be thin webs. Invariably, these are iatrogenic as a result of somebody operating or removing a vocal fold lesion very anteriorly. Sometimes they're congenital as well. If they're thin, they can be divided. There's a technique that one of my colleagues in Turkey uses where he divides it sort of tangentially and is able to sew flaps, one on each side, in order to keep these from reforming in any significant way. There's usually still a small portion anteriorly. You can apply mitomycin C again to this group to decrease the likelihood of recurrence. If it's a thick web, however, your results definitely are not going to be as good. And you have to think about either an endoscopic or an open treatment with a keel. You can place keels endoscopically. This is the technique here from an artist's illustration, where through a laryngoscope you're able to pass sutures in through the cricothyroid membrane and through the thyrohyoid membrane, and then pass the keel in endoscopically and suture to the outside. It doesn't even necessarily be a keel. You can actually pass a small tube, little plastic tube like IV tubing, to hold that space while it's healing. Open, sometimes we have to do that here, and this is a patient I had to do that on. You can see that the larynx is split anteriorly, so we did a thyrotomy. You have sutures here. This is the thyroid cartilage on each side, tracheotomy down here. And again, when we're done, usually some kind of umbrella keel, or sometimes we'll put in a finger cot, so basically part of a glove filled with Vaseline gauze to kind of hold that space. Although again, because it's not so sharp in the front, you can get some blunting, and this works much better in that regard. For posterior glottic stenoses, these are going to, again, like I showed you earlier from the pathophysiology slide, most commonly are going to be from intubation from that endotracheal tube sitting right here. Very important here to evaluate the cricoarytenoid joints because they could be fixed. If you've had this for a long time, even though the joints were initially mobile, with time, if left untreated, those joints can be fixed. It's like, your knee, if you don't use it for quite a while, you won't be able to use it. It'll just freeze. Sometimes we have to do a laryngeal EMG just to evaluate the muscle function, although that's rare. So again, whenever you have a problem like this, that's a difficult one to fix, there is going to be lots and lots of different operations, and including here. So a variety of things have been done. A micro trapdoor flap where you kind of incise the mucosa, lift it up, cut out the scar, lay the mucosa back down. Often when you cut this mucosa with a laser, it'll shrink up, and then even if you remove all the scar, you may not be able to lay it back down. But again, a variety of things are available. Certainly as a last ditch, if you've tried everything and things still aren't working, then a arytenoidectomy. Very important if you've got joint fixation, this is probably what you're going to have to do. Unfortunately, this always comes at a price. So when you do this, you give them more airway, but their voice isn't going to be quite as good. So I can tell you this is kind of the best possible situation with a posterior glottic stenosis, right? You got the scar band here, you've got space behind it and in front of it. So all you have to do is go in here with a laser or sometimes just sharp instruments that take off the scar band, and this is what you're left with when you're done. Picture isn't quite so, here we go. Look at that, the joints are mobile. Even though you got a little bit of posterior glottic insufficiency here, you got a big gap where the tube was sitting, at least from an airway standpoint, this patient is going to do quite well. You hit a home run there, right? And here, I show you somebody who's having an arytenoidectomy. So again, this is endoscopic view looking at a larynx. This is the right arytenoid here, and you can see my laser cuts. And usually I elevate up a flap, remove some cartilage, and lay the mucosa back down. Because you've gotten rid of the cartilage, you have a lot less bulk. It's easier to lay that mucosa back down, although it does shrink some. If I can, I'll try to put in a few stitches here. Again, it decreases the raw surface that's exposed, so less likely to get granulation, and they generally heal much better. Well, let's see. So for let's go back one. So a complete glottic stenosis, like in this patient here, invariably that's going to be some kind of unrecognized external trauma. For example, somebody who's got some external trauma, they're intubated, the tube is left in, they wind up getting a trach and kind of forgotten. So along with the glottic stenosis, invariably you're also going to have some subglottic injury. And just be aware, this is going to be the toughest group to take care of. Right, no matter what you do, it's going to require multiple procedures, both endoscopic, open, and very often you may not ever get them better. So you need to really manage expectations in this group, that they're not going to do so well. Much better to try to avoid this situation by recognizing, trauma, getting those tubes out earlier, traching earlier, and fixing the trauma earlier. Subglottic stenosis here, this is a typical example. Generally, you're going to do quite well as well. I treat most of those endoscopically. Again, this is just the office exam. Here he is after treatment. Again, a little shorter view, but you can see the subglottis here is completely open. This is the same patient a month out. This is what he had done. This is the it'll clear up. And so here it is working through the laryngoscope in a subglottis using the laser to make radial cuts here at 12 o'clock. Usually in a subglottis, it's pretty thick and I can do 4 cuts, 3, 6, 9, and 12 o'clock. But again, sometimes you have to tailor that to the specific stenosis, followed by dilation, mitomycin C, steroid injection. Again, they do quite well. Let's see. Once in a while, however, that is not going to work, and you have to resort to open laryngotracheoplasty. Now, again, this is much more widely done in children than in adults, particularly with these cartilage grafts, anterior and posterior grafts, although in children now they're often even putting the posterior graft endoscopically, not open. This is the typical technique. It doesn't work quite so well in adults. And the reason is they just don't heal quite as well. Again, children have this remarkable capability to heal quickly. Adults lose that. The blood supply isn't quite as good, and this doesn't work quite as well. Although again, sometimes we do use it. This is one patient that I used it in. This is a cartilage that I removed, and here she is. So I again divided the anterior thyroid cartilage and the midline thyrotomy. Posterior cartilage is also divided, and I have a right angle clamp in there, opening that up, splitting that posterior cricoid. So then I was able to drop in a graft. This is actually much harder than it looks, because you're working through a very small little window, and you've got to put some stitches in to hold that in place. But again, it is doable. It doesn't work quite so well with an adult, but in some cases it is necessary. More often than not, this is what we wind up doing in adults, and actually more so in children it's being done as well, which is a cricotracheal resection. So you can resect most of the cricocartilage, certainly anteriorly. Posteriorly, obviously you can't, or else you lose the structure of the airway. But you can anteriorly, you can take it all the way up to the thyroid cartilage. And you can resect part of the trachea as well with it. So this is a patient here that we did that on a couple of years ago. She has a tracheotomy already, and we just intubate through that. We also intubate from above, because once we resect, we're able to pass the tube through. So here she is. So, flaps are elevated. The straps here are divided. You can see the thyroid notch up here. There's the tracheotomy, area of stenosis. So again, I've divided, and we're taking that out, the area of stenosis, along with the tracheotomy. This is the area that I resected, not terribly long, a few centimeters, a couple of centimeters, and that's a good size. You can resect up to about 4.5 easily, 4.5 centimeters. More than that, you have to be careful, and you have to, do some releasing maneuvers. And when we're done here, you can see that these are my stay sutures. We're bringing the trachea up, right up to the thyroid cartilage here. The posterior cricocartilage is intact. And here she is after she's closed. Again, multiple stitches. We usually use a variety of things. So usually PDS is my favorite to bring this together. And I leave some Prolene stay stitches in during the healing. Tracheal stenosis, again, this is going to be your most favorable outcome. Short segments are best treated with laser. They do quite well. The CO2 laser is my favorite tool for these, and we do this with a subglottoscope where we pass through the vocal folds and work directly on the upper trachea. If it's really distal, you might have to do a rigid bronchoscope, although again, think about the pathophysiology with the cuff. So invariably, most of the injuries are going to be a couple of centimeters, 2, 3, 4 centimeters below the cords. And that's going to be easily accessible with a subglottoscope. I wrote here 3, 6, 9, and 12. In reality, is you have to be careful posteriorly. Because remember, a posterior tracheal wall is membranous. So if there's no, again, if there's no significant scar, you don't want to resect, you don't want to laser back here because you run the risk of getting a fistula. And if there is scar, you have to take care of it very carefully so that you don't overshoot and cause them a problem. So we make our laser cuts followed by dilation of mitomycin C. This is again an up close view. You can see here I did 3 incisions, so 3, 9, and 12, and then dilated, left the posterior wall alone. I'd injected, so before I dilate, I inject steroids into these islands. And then when I'm done, I apply mitomycin C. This is all done with jet ventilation, which can be done a couple of different ways. This is the subglottoscope that I use, and it's got a catheter in it that actually you're able to do it without blocking your view at all with the tube, which is very, very important in doing the work, but you can't do this with an endotracheal tube. Unless they've got a tracheotomy already, there's no other way to do it easily, except through jet, or once in a while you have to do this with intermittent apnea, where you intubate for briefly and then work without a tube briefly. But this, again, in my hands, in my practice, works best using jet. Then we dilate a variety of, we have copper dial, or these are actually brass dilators. These are probably the original ones that Dr. Jackson used that we still have today. Balloons are much more effective, and I was an early cynic regarding their use, but have really, over time, become a big fan. I think they work incredibly well in giving you a nice, strong circumferential dilation. Let's see here. So here's a patient. Here's somebody, again, I'm working through the subglottoscope and the upper trachea. Similar technique with the laser, again, making my radial cuts. You can see the helium neon aiming beam here. The patient is getting jet ventilated, so there's nothing in my way while I'm working. You do have to keep the oxygen obviously very low, even though there's technically no tube in there to burn. You've got to make sure that they keep the oxygen below 40%, or else you'll get a lot of popping and sparking. And this will clear up in a second. So after I have lasered, I'll dilate. This is the balloon. And there are a couple of different ones on the market. There's rigid and semi-rigid. I wind up using the rigid most of the time. And there you go. So after laser, steroid injection and dilation, looks beautiful, right? And then we apply mitomycin C at that point. Okay. Once in a while, the anatomy is such that you just can't get access to the patient's subglottis and upper trachea. There you have big maxillary teeth, or they have cervical spine issues where they can't extend, in which case you can put in LMA. This is a laryngeal mask airway here, and I'm using a flexible bronchoscope through it and a flexible CO2 laser fiber. You don't have quite the same control as you do with a rigid laryngoscope, subglottoscope, bronchoscope, and a micromanipulator where you get an inline site and able to manipulate the tissue. But in some cases you have no choice, in which case this works well. And it's a good option to keep in the back of your pocket. Again, as a technique that can come in handy. This is a kind of a special situation. This is called an A-frame deformity. And Dr. Grillo and his colleagues up in Massachusetts General described this years ago from a tracheotomy, often vertical incision. If there's torquing on the tracheotomy tube, there's loss of cartilage, and then there's this collapse laterally to give you that so-called A-frame. It almost looks like a second set of vocal folds. So again, my colleague over in the UK, Guri Sandhu, came up with this technique that he coined the term endoscopic laryngotracheoplasty. You can see here where the tracheotomy was, and this is a patient of mine that I've done this on, where you resect laterally. So you kind of make these, elephant ears, one on each side, 3 o'clock, 9 o'clock. You don't just make a cut, you actually make a resection, you remove, and he'll take it all the way down to cartilage. I'm not quite so brave, but I'll take it down enough to widen the airway significantly. He's reported even going all the way out to perichondrium. You do have to be careful about leakage of air and subcutaneous emphysema and infection, et cetera. So you have to be much more careful in that regard. But here it is. After we're done, we apply mitomycin C, and this patient did very well. Followed him for almost a couple of years, and he's had no recurrence and is symptom-free. So it just does work well. Once in a while, you've got to put in a Montgomery T-tube, and most often in my practice, I'll do this for patients that have had failed laser therapy, for example. You operate on them, you laser them, you dilate them, you put all the things that we've done before, yet they still, the scar reforms or collapses. Often we see this in patients that have a lot of inflammation still. Remember, it's a cartilage disorder and acquired, and if you've got a lot of inflammation in the cartilage, that has to settle down. So sometimes in that group, I'll put in a T-tube and treat them with antibiotics and steroids and give it a little bit of time for that inflammation to cool down. And by the time you take that out, you get some stiffening and it stays open. Patients that are poor surgical candidates, so you can't operate on them at all for a variety of reasons. They just can't tolerate general anesthesia, et cetera. This may be an option, although more and more I'm favoring tracheotomy for that group. T-tubes do require a bit of care. The patient has to be able to suction the superior and inferior limbs. Let me see if I can show you pictures here. So this is somebody who's collapsed. You can see kind of this almost Malaysic picture. And here it is with the T-tube in place. So this is the T-tube here. So you have to be able to suction the upper and lower limbs, and this is closed. So patients that don't have good manual dexterity, don't have a good social support system at home, will have difficulty. So we have to make sure we pick someone who's going to do well with this. Again, like I was saying, they do have to get changed every 9 to 12 months. This is it in the patient. Anterior view. Because if they don't get meticulous care, this is what's going to happen, right? Usually I change them every 9 to 12 months on average, sometimes before. They do build up this biofilm. This is a sad case where this was left in for 17 years. Yes, 17 years. It's hard to believe. I didn't take this out in the office because I was afraid if I pull, this was going to tear and we're going to have a foreign body in the airway. So we did it in the operating room under a much controlled circumstance, and we're able to get it out in one piece, thankfully, and replace it with actually for him, I just put a tracheotomy tube in. He's been doing quite well. So patients who fail all that, so let's say you've laser resected, tonight they keep recurring. You put a T-tube, they're still recurring. Or if they've got a malasic segment, meaning that the cartilage is lost and they've got collapse, and that group isn't going to do well at all with laser, what do you do? Well, you're left with tracheal resection. Some people would argue that everyone should have everybody with stenosis should have a tracheal resection. That certainly, in some people's hands, works quite well. It is a bigger operation. It takes, a few hours and, a length of stay in the hospital that could be a week or 10 days or maybe even up to 2 weeks. But long term, they probably do better in that they don't require so many procedures. So you have to tailor it to your patient. And, and again, you have to tailor it to the stenosis. You don't want to keep lasering a stenosis over and over again when it keeps recurring. So in my practice, 2-3 times, if they're recurring after 3 times, then it's time to talk about an open resection. Hopefully they're healthy enough, and again, this is best done in patients that are young, patients that have minimal comorbidities, they're not diabetic, or if they are, their A1C is at a reasonable level, 6, not 8 or 10, because they heal better. Obviously, hopefully not had previous neck surgery or sternotomy, because again, that decreases the mobility of the trachea. This is someone here. So my practice, the biggest group that you're able to do these on are these young trauma victims that have had injuries. And again, they're young and healthy, and will generally do pretty well with this resection. So here it is, the area after it's exposed. So the patient's head is up here, feet are down here. The strap muscles are divided, and here I have the area exposed. This is often pretty inflamed and scarred, even if no one has been in their neck before. So here it is, the trachea is transected. And then I intubate from below. The area of stenosis is removed. Now I've taken out the endotracheal tube and we intubate from above. So the intubation with the tube from above is passed through now, and they're able to ventilate this way. And then we're able to put in our stitches. These, again, multiple PDS. You have to put a posterior row and an anterior row. And then you close up, and this is what it looks like when you're done. We often put this Grillo stitch. There is another technique that one of my colleagues developed, which is you put one of these stitches more inside, so it's not quite as unsightly. This looks actually pretty gruesome for most patients, but nonetheless keeps them from extending their neck, which is very important during the healing phase, which is again a few weeks. Sometimes we have one of these devices made up which keeps their neck. This was done by an occupational therapy department to keep their neck flexed. A little more humane than a stitch. Post-operatively, these patients are in the ICU. They're on antibiotics. They're on proton pump inhibitors. We try to avoid steroids as much as possible. We give them humidification. And you have to watch them very carefully because they sometimes do get swelling early on. And when they do, they can get quite stridorous and nervous, and you've got to prepare them for that. Here's one that I resected recently with one of my thoracic surgery colleagues, because this was almost 5.5 centimeters, so nearly half was received. This is a month or so post-op, going through the cords. This is in the office. And here it is. So this is after we're done. So the point here, it's not 100% open. This is not 100% of normal. So even when you resect these, you'll have some narrowing post-op, although, hopefully it will not be enough to make them symptomatic. Once in a while, you have to go back even after after you've resected them and do some touch-up endoscopic procedures. That's okay. But again, overall, they do quite well in the right patient. With resection. You can see one of the stitches left here, that all the others have resorbed. And distally, it looks good. And this is a young woman who had a very long, she had almost 5 centimeters of stenosis and was 100% scarred. So, endoscopically did nothing. Endoscopic technique would not have worked for her. We tried, it was just nothing you can get through, it's too long. So a perfect candidate for resection, although it was on the long side. And this is from our series back in 2007. Again, this was 74 patients. We have almost 200 patients that we've done since that time. But you can see the results that we had at that point. Again, we had 52 of the 74 patients actually required surgery. The average was about 2 procedures per patient. And you can see a variety of things were done. So CO2 laser, dilation, mitomycin. Some just got tracheotomy. We had 3 that required T2 placement, 2 to laryngotracheoplasty. Some of these patients with trachs went on to resection. Some of the ones that were endoscopically treated went on to other things, including resection, including T2 placement, including tracheotomy. And we had long-term follow-up on 42 of the 74 patients, and we were able to show that we were able to decannulate about 50% of them. And you know, to nowadays, again, with the better techniques, so we're able to decannulate even more, but still, you'll never ever get 100%. Again, this tends to be a very sick group of patients. And, you know, some of them are going to die of their disease. You know, again, 34%, this is not from what we did. This is basically from their underlying condition. And then some, again, another 16% is, you know, permanently tracheotomy dependent. So this is why, so with the results like that, and, you know, even if you're a little bit better now, I would say we're a good 70% or 75% decannulation rate if you choose carefully. But still, you know, it's less than perfect. You know, surgeons, we always want to, we want, 90 and 95% success rates. So this is why we were so excited back in 2008 when this paper came out. And this is from Macchiarini's group over in, he was in Stockholm at the time. This was a young woman who had had TB and intubation, had a subglottic stenosis, had a left main stem stenosis. And the subglottic stenosis was resected surgically, much like I showed you earlier. But this one, even, you can't really resect that easily. They stented it for a while, and then she rejected the stent and had some issues. So they talked about, and they did for her, putting a transplant. They really were able to get a tissue engineered airway that they replaced this with. And again, this was presented in multiple journals. This is in The Lancet, which is a very prestigious journal in the UK. And we have presentations at our ABA and other societies. We were all very, very excited. Certainly I was, given my practice. Fortunately, again, let's go back. Let's say it's a year later, the same group actually presented using not tissue, actually creating an artificial nanocomposite. So basically creating an artificial trachea made of a composite material, seeding it with stem cells, and then doing a similar thing, replacing tracheas, replacing bronchi. And again, we were even more excited, again, even easier to get something off the shelf rather than have to get a cartilage and then decellularize it, which is quite a labor-intensive process. So again, we're even more excited. This was in 2011. But unfortunately, again, with all, as with many things, it was a little bit too good to be true. And it wasn't too long after that reports came out that maybe the results weren't quite as good as initially reported. In fact, there was an investigation into these bioengineered synthetic tracheas, and multiple reports came out, including an investigation at the Karolinska where these were done, and really turned out to be quite a scandal. There was a whistleblower from the inside, and really realized that this data was not all that it was presented to be. Many of these patients, most of them went on to die. I unfortunately had the opportunity, to take care of one of the last patients. And this was her video. This is a bronchoscopy through her tracheotomy tube. This is the synthetic trachea, and this is her native trachea. Certainly, this was more than a couple of years or more after transplantation. The sutures are coming apart. Certainly doesn't look very alive, which is what they were billed as, that they would realign and be almost no different from native trachea. And this is distally. Again, synthetic trachea, native trachea coming apart. Here it is again. Again, looks pretty dead at that point. So this has really inspired us and our group to look at and study tracheas, and this is some of the work that's being done in our laboratories, and this is with Dr. Plechko and her group at the bioengineering department at Temple. So this was one study here where we looked at both biomechanical and spectroscopic assessment of human cartilage, and this is human cartilage, human trachea sections here. We're able to test the stiffness, determine the stiffness by compression testing. Most studies that were done before had used tensile strength, where they stretch it and determine its stiffness that way. But when you think about an artificial trachea, what's more important is really compression, because that's what it's exposed to, is some compressive, more compressive forces than tensile forces. So we're able to determine here that based upon age, so we had different tracheas from different ages. As you get older, as the tracheas got older, and we define that as 50 arbitrarily, so above 50 and below 50, that the tracheas became much less stiff with time. So, and then using the Fourier transform infrared spectroscopy, we were able to determine that it was the collagen content that was associated with stiffness. So the greater the collagen content, the more stiff. The younger patients had much more collagen. The older patients had far less collagen, and again, a lot less stiff and more compressible tracheas. Proteoglycans as well. Now, proteoglycans are, again, is one of the GAGs or glycosamine, glycosamine glycans that are present in trachea, and they're very important in attracting water and allowing compressibility and, given its strength and resistance to compression. And again, with age, the proteoglycan level went down. So the older you are, the less likely to have, you had far less proteoglycans in the trachea. So again, which meant that you attracted much less water, you had far less water content, which also decreased with age. And then your compressibility was, your stiffness was much less with time. We're able to compare proximal and distal trachea. Again, most of the disease that we see that needs to be treated is proximal trachea. And a proximal trachea actually had less water content than the distal trachea. That was an interesting finding. The infrared spectroscopy can actually be done through this probe. Probe is a little bulky, but it can be used endoscopically. Here, this was proof of concept. This is, again, not a great photo, but here I'm passing the probe through a standard laryngoscope into the trachea, so you can get direct data from examining the trachea that way. And this is, again, our most recent work, where, again, through our bioengineering laboratory, we decellularize tracheas. So you take human trachea, native trachea, through a detergent enzymatic process, which is quite laborious. This takes almost a month to do. You can break it down to basically not just, to basically a scaffold that is completely decellularized, which is very important because it shouldn't have any immunity. So this has been done before. We certainly weren't the first laboratory to have done this. In fact, that first young transplant patient that was done by Macchiarini's group, that's exactly what they did. They got some trachea that was decellularized, and then they reseeded it and implanted it. But we were the first group to use this mid-infrared Fourier transformed infrared spectroscopy to examine this. So this is a great non-invasive technique that you can use to evaluate the process during the decellularization. That's kind of what we did here. So we're able to show the differences in collagen and proteoglycans that took place during the decellularization process day by day. These are day 1 and day 25, just some samples, and compare that to the more invasive techniques, which is histology, where you actually have to take a section. Again, useful technique. So just in summary, I would say, as I presented, I think it's pretty obvious that this is a very challenging problem. Airway stenosis, particularly in adults, is a challenging problem. You have a variety of different tools and techniques that are at your fingertips. You need to be comfortable with many of them. You need to have a system in place to do this. You have to have anesthesiologists that know how to do jet ventilation safely. We're doing sometimes 3-5 cases a week, all on one day usually. So again, we've got a system down that can do this regularly and rapidly and safely. And then, and for resection as well, you need to have the ICU staff, you need to have the pulmonary backup, you need to have the thoracic backup in order to do that safely. So, and if you do this right, you'll have very, very happy patients. So I always like to get them as they're coming out of the operating room, because we do extubate them right in the operating room after a section. They give you the thumbs up, and even months later, they're still happy. They just have this nice necklace that goes around their neck that hides the scar. But the future is bright for this condition. I think there's a lot of research being done. And I think this, between, eliminating it by picking out which patients are genetically predisposed and more likely to have it, and treating them earlier, and to different techniques that we use, and, different research that's come up and coming, I think the future is going to be very bright. So I'll, again, thank you for your attention. I hope this is helpful. And if there's, be happy to stop here and ask for any questions.